adenomycin. Now the next question starts. What is a sequential approach? In sequential approach, we have a visceral situs, great artery connections, atrial situs, atrioventricular concordance, and ventricular localizations. The first comes a visceral situs. What is this visceral situs is? We have to have a situs. If I show this image properly to you, then you'll say, if I put my probe perpendicular into the subcostal space with the index marker on left hand side, how do I see? I see a spine over here, aorta over here, IVC over here. And when I see aorta on the left hand side, look, this is anterior, this is posterior, this is left, this is right. So my aorta is on the left hand side, my IVC is on the right hand side. Posteriorly is spine, anteriorly is a rib. And that's what the visceral situs is. Then I move this probe anteriorly, the footprints anteriorly. So this IVC opens up, where we see a so-called structure where IVC open. This is so-called as RA. And then whatever the structure which is attached to RA, it could be an either tricuspid valve or a mitral valve. And finally, we move our transducer from subcostal window, sliding down all the way to apex, and the other structure is left atrium, if this is RA, which has got the pulmonic venous drainage. Now the fixed structure is IVC will always drain into the RA. Other fixed structure is it will LA and LV will always have a pulmonic vein. There can be some aberrations where the pulmonic venous structure may be draining to the RA. Now this is demonstration, a live demonstration. Look, my probe is keeping perpendicular over it. So here is my IVC, here is my venous structure, and here is my aorta. Let it play more. So this is my spine, this is my structure which shows a respiratory variation, and here is some pulsatile structures. Now more, with colors, here is a spine, here is a structure which has got a respiratory variations, and then this structure opens up to so-called morphological RA that we suggest. And whenever this suggests, IVC will opening into the RA. And that's what is the most important thing is, this is where the IVC which was seen in a transverse level, when we do anterior rotation, the IVC drains into a structure which is possibly a morphological RA. Other structure is morphological LA, and that we have to prove whether this is a morphological LA or not. And now look, this structure is static image. Here is the IVC, here is a morphological RA, here is a morphological RV, morphological LA. So I have to prove that this is morphological LA by looking at the pulmonic veins. Now this is zoomed up picture. Now very clearly I have removed my IVC from here. Here is the RA, here is a morphological LA. Now you can see a pulmonic veins draining into the structure. So this is possibly a morphological LA. And from there, look, how did I move from there? Subcostal window, I moved to apical windows. So I started with this picture. I started with transverse process, index marker at 0 o'clock, 90 degree into the abdomen. So this is spine, and here is the respiratory variation structure, most probably the IVC. Then next is, this is respiratory flow. Then this structure opens into a morphological structure which appears to be an RA. The other structure has to be LA. So this is LA, and this you can see a eustachian valve or a carry network which is dry, directing blood from IVC to foramen ovale. I show you again and try to freeze you over there. Look. Right. So this is attached to superior margin. This is IVC. Here is the superior margin. Here is the inferior margin. It is attached to superior margin, directing a blood from IVC to the foramen ovale. And that's what is a rudimentary structure, what we see later on. Now, this is a picture in subcostal window. And look how I have moved from subcostal window to the four-chamber view. So here I know this is IVC over here. And this is most probably in RAs. And now I have to prove whether this is morphological LA or not. And how do I prove it? By switching on the colors, this drains into, here is a right pulmonic vein, here is a left pulmonic vein, which you learn over a period of time. Now see the colors now. The colors are arising from a blue, they are away, because left pulmonic vein will show colors away, and the red will show colors towards the program. So this is right pulmonic vein, and this is a left pulmonic vein. If I move this cursor on this side, I'll not be able to see any pulmonic flow. So this is how we say that patient has got a morphological RA and morphological LA. Now you can see it beautifully. You can see this blue color. Now comes ventricular localization. What exactly happens during our intrauterine period? I hope I should be able to show you. Look, this is a paper. It says heart tube folds to the right. So it folds to the right and comes and occupying the left side of my chest. So what will happen? RVRA, there will be anterior, and LVLA, there will be posterior. But how do you see this in pictures? So whenever I'll open my subcostal window, my LV apex should be on the right hand side. And look at this marker. This marker should be always on left hand side of the machine. Let me go back to my previous pictures. So my previous picture was this. I opened up my IVC into a morphological structure. And when I opened up into the morphological structure, my LV is pointing towards left hand side. RV and RA, they are anterior to LV and LA and on the right side. This is left, this is right. Anterior, posterior. So LV, RV and RA, they are anterior to LV, LA and on the right side. And when you see this kind of a picture from a subcostal window, just take for granted that what we are dealing is situs solitus with D loop. All right. So you have to see this picture once you start doing a pediatric echo. Now there are various combinations are present. We can have a left loop situs solitus with left loop, situs inversus with D loop. So multiple combinations are present in this particular. I'm not going to go into detail, not at your level at all. Now we have identified that this is morphological RA, this is morphological LA. Then how do we identify what is LV, what is RV, what is mitral, or what is tricuspid valve? Let me go back to my previous picture in one of those very good picture we had. So if you look at this picture carefully, the tricuspid valve is always apically placed. If I freeze it for you, look, this is the hinge point of mitral valve leaflets over here. This is the hinge point of tricuspid valve leaflet. And normally there is a gap of 5 to 7 millimeter between the hinge point of tricuspid and the mitral. We say that tricuspid valve is apically placed. mitral valve is basally placed. Correct? When we say mitral valve is basally placed, so it is a mitral valve. This is a tricuspid valve. So this is RA attached to tricuspid valve, mitral valve attached to LA, normal phenomenon. Now next question comes, what is my LV and RV? So we take it for granted, this is mitral valve, this is tricuspid valve, and this is an LV, this is an RV. LV is bullet-shaped structure, has got two papillary muscles, lateral and inferior. RV does not have any papillary muscle, but this is heavily tuberculated in the apex. Look, this is clean shaven apex. This is tuberculated or beard apex. So this is clean shaven. This is beard apex. And when we see a triangular clean shaven structure, that is LV, has got a papillary muscles where this is apical tuberculations and it does not have any papillary muscles. All these cords are attached to septum in the interventricular septums. So right ventricular is heavily tuberculated. Scoda inserts to ventricular septum. Infundibular muscle band in the RV apex, or we call them as moderator band. It has got a triangular cavity and there's a tricuspid atrioventricular valve which is apically inserted little towards the apex. This is smooth surfaced, two papillary muscles, elliptoid or bullet-shaped geometry. Two leaflet AML and PML. Tricuspid valve has got three leaflets, septum, anterior and posterior. We can only see septum and anterior wall or posterior leaflet in two chamber views. And the valve is basally placed. All right. Now the questions. Now tell me, raise your hand. What is the difference between this image or this image? That's my exam, whether you have understood correctly or not. Can somebody raise your hand? Let's try. No hands? All right, good. Dr. Muzaffar Ahmed Naik. Go ahead, Muzaffar.
Good evening, sir.
Good evening.
The mitral valve is apically placed, I think so.
This is what apically placed is?
Yes, sir.
Correct. This is basally placed. Look at the hinge point of this valve. This is basally placed. This is apically placed. Correct?
Yes, sir.
All right. Good answer. Now tell me, this is LV or this is LV?
The left-sided.
This is LA. You can see a pulmonic vein draining into the structure.
Yes,
this
sir.
is tricuspid valve, and this is tuberculated RV. So
Yes.
there's an atrioventricular discordance where left atrium is attached to right ventricular through tricuspid valve.
Yes, sir.
Correct? And here, right atrium attached to mitral valve to LV. So there's an atrioventricular discordance. Look at the comparison over here. This is RV is bigger in size because there's an ASD. But over here, this is apically placed and this is tuberculated RV. This is clean shaven LV. Here is a morphological LA, here is a morphological RA. So this pictures tell you that we have atrioventricular discordance. What does it mean by? It means by this LA is attached to RV and then RV may give rise to maybe attached to aorta or RV may be attached to pulmonic artery. Suppose this is attached to pulmonic artery, not to aorta. So what happens? There are two separate circulations are maintained, which is known as what? Transposition of, go ahead, Dr. Mahua. What is known as this?
Sir, TGA.
transposition of great vessels. It means that my AV valves, now they are over here, but my pulmonic artery is attached to RV, so-called morphological LV, now behaving like an RV. So we have TGV in this particular position. Now, another scenario, my LA is attached to RV and now is given rise to aorta. So what is that condition known as? RV gives rise to pulmonic artery. Now these atrioventricular discordance, but at the same time, Dr. Mahua, go ahead.
Isolated ventricular inversion.
No, isolated ventricular inversion is something else. So that becomes congenital corrected transposition of great vessels. What exactly happened? Atrioventricular discordance is present, but the arteries are arising from its own places. All right. So that's how it makes lots of difference. Now, next important issue. Now, this is what we talk of a great artery connections. The third important thing is great artery connection. Look, whenever we do a parachute short axis view, always look the aorta in the center. The pulmonary artery wraps around the aorta. Look at this picture where whenever we see RA, RV, pulmonic artery wraps around aorta and bifurcates. So this pulmonic artery wraps around aorta and bifurcates. This is known as cup and saucer shaped structures. Normal. And if you happen to see two parallel vessels lying close to each other, always think of TGV, transposition of great vessels. All right. Now let's see multiple scenarios. Forget about this picture. Look at this picture. How do I look at this picture? This is normal. Now my aorta arises from RV and this particular structure LV give rise to pulmonic artery. That's again a transposition of great vessels. Correct? No or yes?
Yes.
Here atrioventricular discordance has happened. Despite atrioventricular discordance, if my pulmonic artery arises from here and the aorta arises from here, it means it's a TGV transposition of great vessel with atrioventricular discordance. If my pulmonic artery arises from other side and the aorta arises from here, then it's congenitally corrected transposition of great vessels. All right. So this is an image which you'll see normally. Aorta in the center, pulmonic artery wraps around. And this happens to be a bicuspid aortic valve. We can only see two leaflets of the aortic valve. Look, there are two leaflets. I'll show you them. This is the most common nomenclature. Left-hand side of, this is Rakesh over here. So this is only one leaflet. This is second leaflet. And when we see, and pulmonic artery always bifurcates. The aorta never bifurcates. God has not given us aorta which bifurcates. So remember, the pulmonic artery will bifurcate, aorta will never bifurcate. And similarly, we'll be talking about TGV in next session. When we look two parallel vessels lying too close each other, they don't come labeled as labeled over here. So we have to see which artery is what. If this artery bifurcates, this is pulmonic artery. If this artery bifurcates, this is pulmonic. Then this is aorta, this is pulmonic. Now the questions comes cyanotic versus acyanotic. So I'm not going to touch right now. I'll come down to that later. Next important thing is whether to sedate this child or not. The sedation is one of the recommended method by using trichloryl phosphates, 50 milligram per kg body weights. And that's what is most useful thing is by doing a sedation to these childs. And that's a temporary sedation. And this is a paper from JACE 2014 talking of impact of procedural sedation in diagnostic error in pediatric echocardiography. Look, very categorically said that error among infants and young children are potentially preventable. Sedation is associated with lower likelihood of these diagnostic errors, fewer imaging quality concerns, fewer incomplete reports. But what we do in our lab that's more important is we always scan a child while the child is weeping. We always look at saturations. We want to see that whether the child has got a stenosis or not, or whether the child has got a complex congenital heart disease or not. Complex means what? There has to be cyanosis. There has to be mixing of blood. There could be a TGV. There will be corrected TGV. There could be a VSD with reversal. There could be a PTA with reversal. Or there could be a top physiology. And whenever we see a patient who has got a cyanosis, obviously we try to avoid sedations. And that's what I wanted to say is we decide about cyanosis, and the most handy equipment in cyanosis is one, that is the pulse oximeter. Second thing is we want to see increased blood flow in the system or decreased blood flow in the system of lungs. So we have various conditions where the blood flow will increase, pulmonic blood flow will increase, like atrial ASD, ventricular VSD, arterial like PDA, combined VSD with PDA, and normal or reduced blood flow could be in pulmonic stenosis. Then we have cyanotic diseases with decreased blood flow or increased blood flow. Decreases like TOF, pulmonary atresia. You have a cyanosis, but at the same time, your lungs are oligemic. So that comes to next question is, we always used to look at the lungs, whether the lung field are oligemic or hyperemic. So three take-home message in pediatric population is, we look at the cyanosis level, we look at the lungs level, and we look at oxygen levels. Now, my journey moves to next phase. When we looked at the sequential examinations, then we talk of a acyanotic congenital heart disease. Acyanotic means we have ASD, VSD, PDA, coarctation of aorta, then AS and PS, MS and TS, and then regurgitant lesions. So now, the most important part for any first lesion is atrial septal defect. What is atrial septal defect? Is a defect which is present in the fossa ovalis region, that is secundum ASD. If it's present closer to atrioventricular valve, this is known as primum ASD. If it's present towards the sinuses, this is known as sinus venosus ASD. Till now, you must have heard septum primum, secundum, then sinus venosus ASD. Then sinus venosus ASD could be on the side of SVC or IVC, which we cannot see over here. So that has to need a transesophageal echo. And there's one more variety which is known as unroofed coronary sinus. So let's see what is the pathophysiology. What happens in ASD? A lot of blood is coming from LA, going to RA, then RV, then pulmonic artery, and then comes back to the pulmonic veins in LA. So what structures become bigger in size? RV and RA, they become bigger in size. There is increased flow velocity across tricuspid valve, pulmonic valve, and you see a lot of blood coming from the pulmonic veins. Just get alarmed whenever you see a large blood coming from pulmonic veins. This is a patient with a subcostal window. Here is aorta, here is LA, here is RA, here is pulmonic artery, RVOT, and the pulmonic artery. Till now, I cannot say whether this ASD is present or not. Anybody would like to raise their hand that whether the ASD is present? Without colors.
So without colors, but RA is dilated. That's all we can see.
Correct. If RA is dilated, RV is dilated, we suspect that ASD is present. And whenever we see a suspect ASD is present, the next answer is always to look at the color blood flow. Look at the flow. Suddenly the lot gush of blood which comes over here in these populations. And now the same patient which I showed earlier, here is a defect. So RVRA is bigger than LVLA. What I said earlier, LV is bigger and RV is triangular in shape. So this patient, because it's a volume overloaded condition, is RV and RA, they become bigger in size. Now you can see a lot of blood which is coming on this pulmonic vein on left hand side, right pulmonic vein. And look how much blood is coming normally. So that gives you an idea that patient has gotten a VSD. And whenever we have a VSD, we have to decide what is my TRZ gradient. Higher the TRZ gradient, it means patient is getting pulmonary artery hypertension. We do measure in two different windows. That's not your job. Your job is just to detect ASD. Refer to pediatric cardiologist or pediatrician to take a decisions. And where do we measure? By the way, two-chamber view is, we always measure in short axis view. This is one rim. This is known as atrioventricular aortic rim in subcostal window or subparietal short axis view. Then we have atrioventricular atrial rim. Now we are seeing atrias and we are seeing atrioventricular valve. Then we see the second rims. Nowadays, we are not utilizing this modality for evaluation of the rims. We are using three-dimensional structures for evaluating these rims. Example, here is an ASD. And now you see a blood which is regurgitating back from TRZ to left atrium. What does it mean by? This is mean by the secundum ASD has started showing a reversal of blood flow. It means that PA pressures have gone up significantly high. This is septum primum. You see, look, there's no atrial septum. But at the same time, there is both the valve, AV valves are at the same time. Dr. Veena, go ahead. You want to ask something?
Sir, if there is no pressure reversal, means if LA pressure is more than RA pressure, in that case also we will get TR?
In that case, what we'll get?
Do we get TR? No.
Yeah, TR would be there, but not a large amount of TR.
Okay, this is because of reversal of the pressure.
Because it means my pulmonary vascular, so much of blood has gone to pulmonic systems that pulmonary vascular resistance have gone up and now PA pressures have elevated.
So there will be pulmonary regurgitation also with this.
There may be a pulmonary regurgitation.
Okay.
But this TRZ is significant and this tells you the blood is reversing from right atrium to left atrium.
Okay, sir.
And this is not a good sign.
Yes, sir.
Means it means that reversal of flow is happening. It means the RA pressure is more than our LA pressures. LA pressures are normally 10, 5 in neonatal population. So RA pressure is more than 5 millimeters of mercury in this particular subject. Higher the RA pressures, more is it dilated, and more is the TRZ gradient, more is the reversal, worse is the prognosis.
Patient will have cyanosis also that time.
100%. Now patient will start having cyanosis.
Okay.
And this is what is, you have a common AV canal defect. Like this is not mitral or tricuspid valve. There is only one valve which is present, and this is known as common AV canal defect. Now you can see a beautifully in 3 dimensions view. This is what is you were saying a few minutes back. Look, I gave an agitated contrast saline in this patient who has got an ASD. Look, RA pressure are less than LA pressures. In normal circumstances, there's no reversal of flow. If this patient does a Valsalva, reversal of flow will start happening from RV to RA. What do we do in Valsalva? We increase the intrathoracic pressures. So this is known as negative contrast despite patient has got an atrial septal defect. This is Ampla's device. Look, this is hyperechoic shadow, which is attached to interstitial septum, and this oversized Ampla's device projecting into the mitral valve sides. So if you happen to see this is closure of intra-atrial septum. ASD with contrast. Now see, this is negative contrast. And if you do a Valsalva, there will be a reversal of flow, which will be seen over here. I'll try to show you some pictures for reversals. There's one more variety of unroofed coronary sinus. What do you mean by there's a persistent SVC, which drains into the right atrium through coronary sinus. While draining through the coronary sinus, persistent SVC. Normally what happens is SVC drains to right SVC. So they'll think like SVC over here. So when this persistent SVC is present, this is joining through coronary sinus, and when it's joining through the coronary sinus, it'll have a hole in its roof. Well, that's why it's known as unroofed coronary sinus. So what will happen? You give a contrast on the left-hand side. It will come and opacify first left atrium and then right atrium. You give a contrast on the right-hand side. It will opacify the right atrium and right ventricle first. And that's how this is a pictorial diagram, persistent SVC, and giving rise to unroofed coronary sinus. So it's a volume overloaded condition. Large ASD means chamber dilatation, development of PA pressure, TRZ gradients. Higher the gradient, poor is the prognosis. Now the word about PFO versus ASD. What is PFO? PFO is patent foramen ovale. Now, if I remember what I said, whenever my LA pressure had gone up, this limbus which was opened up because it was allowing blood go from RA to LA. So this is limbus. So this limbus comes attached to intra-atrial septum. So there's a potential gap in this system which is giving rise to a flow in left atrium to right atrium now, or right atrium to left atrium now. So that is known as patent foramen ovale. And now you see this are transesophageal images. The blood is regurgitating back from this side and coming over here. So allow me a second. I'll stop sharing and switch over to other side of my presentation. It'll take a few seconds. I'll show you a couple of pictures where can you see the slides? Yes or no?
Yes, sir.
All right. So this is four-chamber view. Here is RA, this is LA, this is LD. This is a little bit of zoomer up view. Now we give agitated contrast saline into this patient on right arm or left, wherever it is. So you can see a bubble which is migrating through this intra-atrial septum. Now you see a good amount of bubbles migrating from the intra-atrial septum. Look, they're coming from here, this point. See carefully. From here, you can see a line of bubbles coming from here. Again. So if the patient does a Valsalva, you find a lot of bubbles coming from RA to RV. RA to LA, not RV, LA. Now you can see much better. You can see a line of bubbles coming from here. So this is what? Intra-atrial septum and very small tiny hole which is known as PFO. So we say in a very simple word, if it's less than 4 millimeter in size, this is PFO. More than 8 millimeter in size is ASD. Anything between that is small ASD, which needs to be watched. What does it mean by? If we get a PFO, we do not do anything with this subset of populations. If we get more than 8 millimeter of a size, we always try to close them. And if it's 4 to 8, we try to watch them for certain periods. So this is what is in Pediatrics 2006. And this is spontaneous closures. None close spontaneously. Less than 3 millimeter, 100% closure. 3 to 5, 87% closure. So this is why you need to watch. So let's move on from ASD to VSD. Now, ASD was a shunt in between intraatrial septum. Now, the shunt is between ventricular septal defect is in VSD. Now, it could be inlet VSD, outlet VSD, muscular VSD, perimembranous VSD. And this has been seen in this picture. And this classification is valid till now, like it is Soto's classification. Where do we see VSD? We virtually see VSD in every view, whatever we see in our practice. We see in plaques view, we see in short axis view at the level of papillary muscles, we see in 4-chamber view, we see in 5-chamber view, we see a parallel short axis view at aorta. So how do we say that? If we have VSD seen in plaques view, this is known as what? Paramembranous VSD. If this VSD is seen in 4-chamber view, this is known as inlet VSD. If this VSD is seen in 5-chamber view, this is outlet VSD. And whenever we see in short axis view, this is perimembranous, this is muscular, and this is doubly committed VSD. I've made a diagram for this. Let me show this diagram. This is parallel short axis view at the level of aortic valve. This is paramembranous, this is outlet muscular VSD, and this is doubly committed VSD or subpulmonic VSDs. So at your level, just remember this classification. Parasol long axis view, then 4-chamber view, 5-chamber view, and try to correlate this 4 and 5-chamber view with this parallel short axis. So what will happen in VSD? Hemodynamics. A lot of blood is coming from LA to LV to RV. So LV, LA, they'll become bigger in size. So what will happen? You'll see a lot of pulmonic venous flow patterns. Increased increased mitral flow velocity. Then there is shunt present at the level of interventricular septum, the pulmonic artery flow velocity will increase. Now look at this patient who does not have a dilated LVLA. But if you switch on the colors, you see a VSD over here. So this is in plaques window. And if you look at carefully, what is this plaques window is? This is 5-chamber view. Aorta is seen. So this is mid-muscular outlet VSD. Same patient, this is mid-muscular inlet VSD. So this is mid-muscular inlet VSD. And this, we normally don't measure this VSD in size. Now see, whatever I said in my first slides, if it's a muscular VSD, mid-muscular outlet VSD, this is seen in the center of this aorta. This is proximal 1/3, middle and distal. So it is seen in the middle part of this. So this is seen in middle part of this parasol short axis view. So this is mid-muscular outlet VSD. Outlet, mid-muscular VSD. This is perimembranous VSD. Plaques window. And look carefully. There is a bidirectional blood flow. You can see a red color, you can see a blue colors. And whenever you see a bidirectional flow, it means what? LV and RV pressures, they become equalized. It means PA pressure is as good as systemic pressures. And this is perimembranous VSD. So this VSD, which is seen over here, is perimembranous VSD, and this is seen in proximal 1/3 of parasternal short axis view at aorta. Now look at this VSD. Previous VSD was in the middle. Now this VSD is shunting blood both to RVOT and the pulmonic artery. But before the pulmonic valves, if this VSD is over here, this is known as aorta pulmonic window. But if it's before the valve, this is known as doubly committed VSD. Now the question comes, if the VSD is small versus VSD is large. So what do we mean by this? We say that VSD is large VSD or small VSD, that does not make any differences. We always say whether the VSD is restrictive versus non-restrictive VSD. What do you mean by restrictive VSD? If we happen to see a small VSD with large gradient, that is restrictive VSD. It means it's not going to affect the pulmonic circulations. If you happen to see a large VSD with bidirectional flow with reversal of flow, that is non-restrictive VSD. So small restrictive VSD can be left alone, and the non-restrictive VSD needs surgical closings. In ASD, majority of ASD are closed by Ampla's device. In VSD, majority of VSD needs surgical interventions. There's one very special variety of VSD. What that VSD is, there's in between this AV group, like septum, tricuspid valve, mitral valve over here, tricuspid valve over here. There's a flow of blood between this septum and tricuspid valve, AV groove. And through this AV groove, the VSD is present, which directs blood from LV to RA. And this is known as Garbaudet syndromes. Very rare variety of this particular VSD. And that's what I said, restrictive VSD versus non-restrictive VSD. Restrictive VSD means the gradients are very high. Non-restrictive VSD means the gradients are across the interventricular septums are low. And whenever you find a non-restrictive VSD, they need urgent surgical closings. The take-home message from VSDs is pressure dependent. Chamber dilatation is LV/LA. Size does not make a difference. It's just site and the pressure makes a difference. Whether it's restrictive versus non-restrictive, you have to identify them. Very simple take-home message from a VSDs. That was volume dependent ASD. This is pressure dependent VSD. Now comes PDA. What is PDA? Instead of shunt over here, the shunt is at the level of pulmonic artery and aorta. And whenever we have a shunt at pulmonic artery or aorta, the commonest place what we see PDA is parasternal short axis view at aorta, when the blood is rejecting back from descending aorta to pulmonic artery. And any PDA, whenever you see at any age, needs closure. You can't leave that PDA for any reasons. This is what we always do. There's one more view, which you see a ductal view is, we go a space up in Planck's window and we measure how much is my PDA sizes. But at your level, if you happen to see this PDA over here, the reversal of flow from here, this is descending aorta to pulmonic artery, we understand that this is PDA. Remember, VSD and PDA, they are pressure dependent. ASD is volume dependent. All right. Now, look at this picture very carefully. Let me understand whether you have learned something or not. Next picture. Now this is a picture. Anybody, if I put these pictures together, let me just put these pictures together for all of you. Give me a second. If I have taught you correctly, you will give me a correct answer. If I have not taught you correctly, you will not give me a correct answer. Now all these pictures are right in front of you. I just need an answer, somebody to raise your hand and tell me PDA is present or not. Dr. Mahua Rai.
Yes, sir, PDA is present, but likely Eisenmenger is PDA.
Why do you say it's Eisenmenger?
RA, LALV is not dilated, PDA is BD flowing, RV is volume overloaded as well as pressure overloaded, likely severe pH.
How do you say this RV is pressure overloaded?
So there is the LV, the septum is coming towards the LV, so the RV pressure is higher than the
Excellent.
LV.
Mahua, one more answer. You got a correct answer. Great. Look, with every systolic contraction, the interventricular septum is bulging towards LV. What does it suggest? That RV pressure is suprasystemic. RV pressure is more than LV pressures. Correct? If I am able to understand correctly, then why the flow is not there over here? There's no reversal of flow. Why there is no reversal of flow? Because what will happen? LV pressure has to be more than RV pressures. Now RV pressure is more than LV pressures, so hence we cannot see a reversal of flow in this picture, and that is a good example that every systolic contraction is showing up. Reverse this interventricular septum bulging towards LV, suggesting that if LV pressure is 100, this is 120, 130 millimeters of mercury. So the reversal which was supposed to happen from descending aorta to pulmonic artery, it will not happen. All right. Dr. Mahua, now you can try again. How do I prove that this is a reversal of flow?
So do one Doppler. You can do one Doppler. So
Doppler will not give me an answer.
so the PDA is blue flowing. It is coming from the there is PDA, but it is reverse flowing. That is blue flow. Is
So
the
how
PDA.
do I say that this is PDA with the reversal of flow?
And measuring the pressures.
Now, I want to say echocardiographically. Well, what we do in our lab number of times is, and we did the same thing. Look, I gave a agitated saline contrast. It'll come and opacify RVRA. Correct? Now it'll go from pulmonic artery to descending aorta. And where do you see a descending aorta? In the abdomen. Look, the
Yes.
contrast was seen in the abdomen. And one clench diagnosis was made, and this patient was labeled as isolated pulmonic hypertension, PPHN, primary pulmonary artery hypertension. And we knew this question answer because we looked at the saturation level in upper limbs and lower limbs. And that's only we understood that. So my question is, this is what is the most important hemodynamic effects are. You have to be very careful. All right. I'm not going to talk much about PDA. Whatever the PDA, any age, I'll say always close. And it's a very small closer. Like the pediatricians are very happy to do this closer. All right. Now, it could be a combination of anything. PDA with the coarctation of aorta, PDA with VSD. So many permutation combination could be present when we look at these shunts. Now, let me move and show you coarctation of aorta. This is my descending aorta. If you switch on my colors, you see a turbulence out here. And if you happen to see a turbulence, look, this is proximal to the coarctation of aorta. And this is a continuous wave across the aorta. So this is what the Doppler gradient across the aorta is. This is proximal. This is distal. So whatever the proximal gradient is, this is 4 millimeters of mercury, 1 meter. And this is 4 meters, 3 meters. 3 into 3 into 4. 36 minus 4. 30 millimeter of a gradient across this coarctation of aorta. I know majority of you are pediatric adult cardiologists. Where do you see the coarctation of aorta? In which condition you would like to see coarctation of aorta? Well, anybody who has got an unexplained hypertrophy, LVH, always look for coarctation of aorta. I can assure you and tell you, at least one case every 6 months we see coarctation of aorta in elderly population. I'm not going to go in detail on this. Now, unicuspid aortic valve. Single cusp. Then, oh, it is rotated. Give me a second. Try to look this unicuspid aortic valve. Give me a second. Let me rotate it. I don't know what exactly happened to this. This is a picked up from the lab, We were doing this should be seen better. No. These computers are very funny things, But I'll play it like that only. Or it's gone back to the same thing again. I'm sorry, like there's something wrong is happening. Look, it's only single cusp, which is seen over here. Otherwise, rest everything would be normal. Only thing is the gradient across the aortic valve would be large. Now see a bicuspid aortic valve, and you look at this bicuspid aortic valve, left-hand side, right-hand side, and in the front. This is the most common thing on left-hand side combination is present. And this is example, look, this is left-hand side. So we were opening this bicuspid aortic valve. Quadricuspid. You can see 1, 2, 3, 4 cusps. Then supravalvular aortic stenosis. You have a membrane distal to the aortic valve leaflets. That is supravalvular aortic stenosis. There is a membrane below the aortic valve. This is subvalvular aortic stenosis. There are congenital varieties. Whether it's supravalvular or subvalvular, we need surgery. Then mitral stenosis. The commonest mitral stenosis. This is one example for hypoplastic left heart. There is mitral valve which is present, but there is no flow across this mitral valve. Although it should not be over here, because this is a congenital cyanotic heart disease. Then double orifice mitral valve. Now this double orifice is quite commonly seen after mitral clips. Then parachute mitral valve. All these cords are attached to single papillary muscles. And look at a short axis view. You will find only one papillary muscles. The rest everything is normal. Tricuspid stenosis. Here is a tricuspid atresia or tricuspid dysplasia. Pulmonic stenosis. It could be a pulmonic stenosis per se, or it could be a supravalvular pulmonic stenosis. Now see, the leaflet is over here. Leaflet is over here. There is a membrane distal to pulmonic valve. That is suprapulmonic. Now the gradient is at this level. We need resection of this membrane. Then this subvalvular pulmonic stenosis. Here's a valve. There's a muscular band which is dividing the RVOT. Here's producing a turbulence. Now you can see a muscular band over here. And you see a gradient at this point. So there's a gradient of almost 220 millimeters of mercury. Then very common thing, peripheral pulmonic artery stenosis, which is seen in newborns. So when we put a picture, we put a Doppler spectrum pattern at the level of pulmonic valves, then over here. If it's 0.9 or 0.8 meters, this becomes 1.5. We just give a breathing time. This disappears over a period of time. This is one picture from our own patient. Look, we have pulmonic artery over here, but there is no right pulmonic artery over here. His lung was absolutely wide on the right hand side. So right lung did not develop over a period of time. I'm not going to talk about myxomatous valves. And there's an example for submitral aneurysm. Look, here's a mitral aneurysm. It's not abscess. The blood will flow into this aneurysm. It's open. There's a flow of blood into this. So this is submitral aneurysm. Congenital. And this is looking like a double-chambered mitral valve. Double valve. Splayed leaflet, very common in adult population, pediatric population. Again, quadricuspid has come back with significant regurgitations. And this is what we identify our tricuspid valve in pediatric population. So this is septal leaflet. This is AML. This anterior tricuspid valve leaflet. This is posterior tricuspid valve leaflet. Abscene anomaly. So this is a classical example for abscene anomaly. Here's mitral valve, here's a tricuspid valve. But the septal leaflet, the tricuspid valve attached distally. So the TRZ gradient will appear from here. So there's atrialization of right ventricle. Now look at the TRZ gradient appearing from here. And this is a TRZ gradient of almost 36 millimeters of mercury. Severe pulmonic regurgitations. This is complete AV canal defect. I showed you already. Then there's a condition which is known as three-chambered left atrium or right atrium. Two-chambered. Look, this is core tritum sinister. There's a membrane dividing the left atrium. So you have a stenosis not at the level of valve. You have a stenosis at the level of this membrane. Very simple. Go and blow off this membrane. Then we have a core tritum dexter in right chamber. This patient had a mitral valve leaflet replaced, but they left behind this dexter. So now this is where the journey ends. We have come almost to Vande Bharat, and I'm sure we are going to have very soon our bullet train in our country. Now you can raise your hands. Let me have a question answer session.
PFO was PFO.
Any questions? I know this topic is a little different and this is little cumbersome, different, difficult to understand. But we have to have an idea what is going on in this. Dr. Kamal Kishore, what's your roll number? Kamal 28.
20. So good evening, sir.
Good evening.
Sir, can we have PFO against foramen ovale?
What is that? Say it again, a little louder.
Sir, can we have PFO again?
PFO is very small ASD, less than 4 millimeter in size. We don't do anything with that.
Okay.
And often we use a contrast material to evaluate it. Dr. Mal, go ahead.
Hi, sir. Good evening.
Good evening.
With respect to the question which we were discussing at length regarding the reversal of PDA, so in that, the first question, like, why was it PDA in the first place?
Why it was PD in the first place?
Yeah.
Oh, look, when we saw this patient came with PPHN, primary pulmonary artery hypertension. When we looked at his PA pressure, the PA pressures were very high. They were about 120 millimeters of mercury, systolic 120 millimeters of mercury, and the child has come with physical examination. We found that his lower limbs were blue as compared to upper limbs. That was clinical, we found it out. Then we used saturation in lower limbs, which was low. That led to a suspicion, are we dealing with a reversal of flow? When we looked at the ASD, VSD, it was not there. And then the second answer is only left is look at a descending aorta. So we looked at complete aorta. Aorta, there was no coarctation of aorta. And then it led to let's do a contrast. And when we saw contrast in lower limbs, then we were sure that we are dealing with coarctation or the PDA with reversal of flow. We do spend a lot of time in pediatric population. We don't just jump on a pediatric populations. We'll see X-ray chest, we'll see ECG, we look at the child, we talk to the child, we talk to the mother, then we call them at a proper time, we coordinate with their activities. If the child sleeps at 2 o'clock, so we'll call them at 12 o'clock. The child is hungry and fasting 2 to 3 hours. So when we scan in a weeping child and if we are comfortable, then we give them a sedation. And then it's about 30 minutes job, 25-30 minutes job. We always spend a lot of time with the pediatric population. And we are not in a hurry. Like in our lab, we don't jump for anything. Somebody walks in the lab and he wants to get his test done earlier than bypassing everybody's line. We always try to say thank you. We always do work when we are comfortable. We don't do our work when we are not comfortable. If my dopamine are lined up, I can't take any other patient because my dopamine makes a lot of difference. If my stress echo are lined up, I do take a lot of time in deciding my populations. And believe my words, I don't say that we don't have a complications, but God forbid, no complication or it's fatal. People talk of a nightmares in cath lab. I can talk on the top, nightmares in echo lab. This unroofed coronary sinus, which he detected in one of the lady, she had the PA pressures very high. She was breathless. When we gave a contrast in the left arm, it came and opacify whole of the left arm, left chambers. When we gave a contrast to right arm, she came and opacify whole of the right arm. And you know, when we gave the contrast to left arm, what exactly happened? She went into shock. The microbubbles went to coronary arteries, the microbubble went into the brain, and she collapsed. So we
And what? Okay, sorry to intervene.
it need times to do an echocardiography.
So when we have a look at practically, like I'm telling my experience, when we have a look at the pulmonary, I mean PSAX view at the level of aorta, the pulmonary artery, barely like since it's the starting phase, we see the bifurcation of the pulmonary arteries into two. But how do we further change the maneuver to look at the descending aorta and then comment upon the PDA?
When you come to hands-on session, that's what the hands-on sessions are.
Okay.
We help you making those views.
Yeah.
And it's an ever-learning process. Believe my words, I started doing echo in 1986. And today, still I'm learning. I've not learned echocardiography. Every day, the patient teaches us something different. Today, I can quote of a patient. I have that recording done. Proximal LED lesion with no ECG changes. On stress echocardiography. Hardly a minute walk. Patient is dyspneic. Patient is like not dyspneic, heaviness, significant heaviness, chest with sweating. We did an echo. Almost basal anterior septum was almost acyanotic. We got the angiogram done. It was a proximal LED lesion. I said there's a lesion is proximal LED. And the interventional cardiologist called me up. Look, sir, how do you say that it's basal, proximal LED lesion? I said it's proximal LED lesion. So it is the ever learning process. It's not a one day learning process. And when you come to hands-on, then you realize how good these hands-on are for your learning process. And believe my words, it's just the beginning of a journey. You have started riding on a steam engine. The bullet is yet to come. You have to jump from steam to diesel, diesel to electric, electric to high fast trains like Vande Bharat. What is the difference between electric trains and a Vande Bharat train? Tell me, Dr. Mann, what is the difference? What do you understand out of this?
Well,
pardon?
The sophistication.
No. They are both electric. What is the difference between electric trains and Vande Bharat trains?
The interface, the...
No, you have not seen them ever.
Speed.
Dr. Shushma, tell me what is the difference? Anybody can tell me a difference.
Speed of the vehicle.
There is no engine in Vande Bharat train. Have you ever seen an engine in the Vande Bharat trains? Every second coach has got a self-engine. The engines are directly, electric motors are directly driving the wheels of the trains. So they have a quick pickup. It's like metro trains. There's no electric engines in that. Every alternate bogie is being pulled by their own engines. So same is echo. Echo is Believe my words, echo is modifying like anything. And it is meant for physicians. You know who come across first in medical fraternity of a patient? Physicians. You make a diagnosis of acute MI, you make a diagnosis of mitral stenosis, mitral regurgitations, pulmonary embolisms, ASD, VSD, PDA, coarctation of aorta. And then you are directing them where to go. This is a field which is still like vacant us. We are not able to understand the heart failure. 5 important things which are happening in our country is hypertension, diabetes, sleep apnea syndrome, obesity, hypothyroidism. These people are suffering from heart failure with normal coronaries. We are talking of heart failure with preserved ejection fraction. We are talking for heart failure with stage B heart failure. I'll share a paper which I published recently in Indian Heart Journal. Stage B, read that paper. Amazing, 52% incidence in people of hypertensive diabetic population. And anybody knows what is stage B heart failure? All of us are physicians. Anyway, I'll share that paper to you. Just go through that. You'll find there's a lot of vacuum which is happening. Dynamic diastolic dysfunction. When we walk, our LA pressure builds up. We become breathless. So any other questions? Are never-ending talks, I can tell you that. You have not seen the real echocardiography till date. And it is only meant for physician. I'm saying it again and again. If we have 10 cardiologists, we have 1,000 physicians dealing with it. Cardiologists will only do an intervention, but the diagnosis is always made by a physician. All right, let me take quick attendance. Dr. Muzaffar Naik was present. Dr. More? Abhijit More. Row number 3?
Yes, sir.
4?
Yes, sir.
5?
Yes, sir.
6?
Yes, sir.
7?
Yes, sir.
8?
Yes, sir.
9?
Yes, sir.
I must appreciate Dr. Mawar this time.
Yeah.
Excellent understanding of hemodynamics. And that's what you expect from everybody. Roll number 10?
Yes, sir.
11?
Yes, sir.
12?
Yes, sir.
13?
Yes, sir.
14? 15?
Present, sir.
16?
Yes, sir.
17?
Present, sir.
18?
Yes, sir.
19?
Present, sir.
20?
Present, sir.
20 is present. 21?
Yes, sir.
22? 23? 24?
Present, sir.
25?
Present, sir.
6?
Present, sir.
27?
Present, sir.
28?
Present, sir.
Kamal was present. 29?
Present, sir.
20? 30?
Present, sir.
Shankar Gowda. Dr. Shankar, are you there?
Sir, present, sir.
Shankar Gowda is present?
Sir, Ravi Shankar, present, sir.
No, not Ravi Shankar. I'm asking Shankar Gowda. Dr. Subhashish Das, 31.
Present, sir.
32.
Present, sir.
33.
Present, sir.
Ravina was present. 34. Chaitanya Bhujbal. 35. Dr. Samu, are you there?
Present, sir.
Great, Samu. I hope the session was good for you today.
Yes, very good, sir. Thank you very much.
Thank you. So absents today are Dr. Abhijit More, Kirana G, Lavkesh Parihar, Ravi Shankar. Ravi Shankar, you are present, right?
Sir, I'm present, sir.
Okay. All right, there are only 3 are absent. Oh, Dr. Mawa, are you a pediatric cardiologist? Excellent. Where are you based, Dr. Mawa?
Sir, I am from Kolkata. I am senior cardiologist, intervention cardiologist.
Why are you attending these programs?
Sir, I am interested to know the diastolic dysfunction, coronary artery.
Oh my God. Which hospital are you working, Dr. Mawa?
Sir, right now attached to RN Tagore and BM Birla, and I am also DNB examiner for pediatric cardiology.
My God. Great.
Thank you, sir.
So Dr. Mohammed Ismat, online.
Present, sir. Present, sir.
Dr. Priya Barata Das. Priya, are you there? Dr. Miss Priya Ravinder Singh, I don't know.
Present, sir.
Present, Priya. I'm sorry. Ravi Kumar Nyamala. Shamina Sultana.
Present, sir.
Mohammed Shahbaz Kareem. Satyam Likha. Tejasvi Mathur. Mohammed Jaid. Qasim Ali. Mohammed Qasim. So there are only 4 are present. One is Mohammed Ismat, Priya Ravinder Singh, Samina Sultana, and last is Mohammed Arman Jaid. Great. So with this, let me pay thanks, and next time we'll have a session on congenital heart disease, Cyanotics one. With this few words, let me pay thanks to each and every one of you. I'll still again invite all of you who are living close to Delhi. Please join us on 17th. I'll send you a link again. Please register if you have not. The registration is complimentary but mandatory for logistic reasons. Good night. Shabba khair. Stay safe. See you next week.